everyone. Hello, everyone. Welcome to today's webinar. Thanks for being here. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health. I work with the Program for Injury Prevention, Education, and Research, also known as PIPER, and I facilitate the National Peer Learning Team on Child Maltreatment Prevention, which is hosting this webinar series. Today's webinar is the first in our series on research and progress on adverse childhood experiences and child maltreatment. And the National Peer Learning Team is a national network of people working in public health and social services who come together to learn about primary prevention approaches to child maltreatment. It's funded by the CDC, and it's a partnership between the Colorado School of Public Health and the Colorado Department of Public Health and Environment. So we're very happy to welcome you here today for a webinar on research and progress on opioids and child maltreatment, neighborhood factors to protect families. The purpose of this webinar series is to share research that's at various stages of development and also to help bridge the divide between research and practice and help to facilitate a discussion about these important topics. So we're very glad you could join us today. I'm going to do a quick housekeeping here about Zoom. Probably everyone is getting a lot of time on Zoom these days, but you can use the Q&A feature in your Zoom menu to ask any questions throughout, and then we'll do some Q&A after the presentations. So please feel free to put your questions as you think of them into the Q&A box. Also, we are recording today's session, and the link will be sent out afterwards with the slides, and we'll post it on our website as well. I did want to let you know about some upcoming webinars that we'll be holding. In May, we have a webinar scheduled on building community resilience, addressing the pair of ACEs and preventing child maltreatment through a cross-sector approach. And in June, the topic will be evaluating organizational policies to prevent child sexual abuse. If you haven't registered and you're interested in registering, please check out our website, and we'll also send out the registration links with the follow-up email for this session so that you can get signed up. So before we move ahead, I do want to do a quick poll just to hear about who we have joining us today. So I'm going to open up a poll here for you to share. What sector do you work in? And this will be helpful to us to know where you're coming from, and also to our presenters to kind of ground in the different groups that we have. So please take a moment and vote. I see lots of votes coming in. And they're still coming, so I'm going to give it about 20 more seconds for votes to come in. Okay. Great, looks like almost everyone now has voted. So let's share so you can see what we've got. So it looks like 30% of our attendees today are from the nonprofit sector. And then also a significant group from public health and human services and education. And some from healthcare. One person from business and industry, and a few from other sectors. So that's great. We've got a really nice mix of different sectors here. Thank you all for sharing that. So I'm gonna close that out. And now I'll go ahead and introduce our speakers who will be talking about their research today. So first we have Nicole Michaels. She's a senior research scientist at the Center for Injury Research and Policy at the Abigail Wexner Research Institute at Nationwide Children's Hospital. She's also an adjunct assistant professor in the Department of Pediatrics at the Ohio State University College of Medicine. And Dr. Michaels' primary research focuses child maltreatment, particularly in the context of parental substance misuse. She has more than 15 years of experience working in the field of pediatric injury prevention, both as a health educator and as a scientist. And then we also have Bridget Freistiller. She's a professor and associate dean for research and faculty development at The Ohio State University in the College of Social Work. She runs a research program focusing on innovative approaches to studying child abuse and neglect, including the study of drinking context related to the use of physical abuse and neglect, and the use of GIS and spatial analysis to understand the spatial dimension of abuse and neglect. She's an expert in the application of population-based geospatial research methods in understanding alcohol and drug-related problems related to the availability of substances through drug distribution systems. So now I'm going to hand it over to our presenters to share more about their research, and just remember to put any questions in the Q&A box and we'll field questions after they present. So Nicole, you can share your screen now.
All right, and Bridget is sharing her screen, so I'm just going to let her know when we need to change slides. But good afternoon and good morning to all of our colleagues out on the West Coast. And thank you, Sarah, for the introduction. Bridget and I are super excited to be joining all of you today to discuss our current study on opioids and child maltreatment. Next slide, please. So we're going to start here with a map of Ohio. In 2015, Ohio was among the top 3 states in the country for the highest number of opioid deaths, synthetic opioid deaths, and heroin deaths. And between 2013 and 2015, Ohio saw a 44% increase in the rate of opioid overdoses due to prescription, in the rate of drug overdoses due to prescription opioids and heroin misuse. So the map that you're looking at right now shows naloxone administration rates per 10,000 people by county. So we can use naloxone administration as a proxy for opioid overdose rates to show us what's going on in different areas of the state. So the red lines you see there are interstates that cut through Ohio. And as you look, you can see how the rates have changed over time from 2003 through 2015. So the little, you can see the date changing in the right-hand corner there. And the state progressively gets darker and darker, but you can also see kind of the shifts across different areas of the state. Next slide, please. So opioid overdoses have become increasingly important to discuss when we're thinking about the child welfare system. So even though Ohio has been focusing on opioid overdoses for many years, it's only been recently that the effects on the child welfare system have been discussed in as much detail. Yet the opioid crisis has been affecting some of our most vulnerable populations, our children. So these are just statistics about opioids and child maltreatment within the state of Ohio. 1 in 4 children in Ohio are placed in foster care due to parental substance opioid misuse. And then when you look at children under 1 year of age, that proportion increases to 70%. We know that parents with heroin use have lower rates of reunification with their children, and parents who misuse heroin have longer stays, their children have longer stays in out-of-home care. So it's a significant problem and really impacts our children in the form of foster care placement and adverse outcomes. Next slide, please. So this is just some information about other studies that have been conducted looking at opioids and child maltreatment. So in Florida, we know that counties with higher rates of opioid prescriptions have many more children placed in foster care for child neglect. However, there's greater variation between the relationship between prescribing patterns of opioids and out-of-home placement at the state level. In the state of Tennessee, they saw higher rates of substantiated reports of child maltreatment in counties with higher levels of prescribing opioids. So it's not surprising that the child welfare system in Ohio is also overwhelmed from responding to abuse and neglect due to the increased use of opioids. We also have looked at additional research out of California that found that overdoses of prescription opioids at the community level were associated with a 2.06% increase in child maltreatment hospitalization discharges and a 1.27% increase in discharges for child injury. And this is significant because the use of hospital discharge data represents those more serious incidents of child maltreatment because they required at least one overnight stay in the hospital to be included in that study. Next slide, please. So now we're gonna dig down a little deeper and take a closer look at another one of our maps, just to kind of give you some background on what we're doing currently in our study. So here's a map similar to the first, but in this one, we're looking at the rate of naloxone administration by census block groups. So census block groups are much smaller than counties and really allow you to see changes in time at the much smaller geographic levels. So these census block groups are similar to what you might consider as a neighborhood within a community. So here we have two Ohio counties, Pickaway County on the left and Fairfield County. And again, you can see the changes in naloxone administration over time. So we go from 2003 again through 2015. Next slide, please. So now we're going to look at the static maps just to kind of dig down a little bit deeper into what's really going on here. So when you look at the static maps, that you can see that it's not just the city centers in Fairfield and Pickaway County that have seen those increases in overdoses. You can see that overdoses have spread to the more rural parts of the counties as well. So if you look at the 2003 map on the left, the very dark area in kind of the lower right-hand side of Pickaway County, that first little dark area there, that's Circleville, so that's the county seat. And then in Fairfield, again, the darker area in the middle is where the county seat is. And so when we showed this map to one of our community partners, he remarked that he was expecting the increase in Circleville, which is the county seat, but was surprised to see the distribution across the county. So if you look from 2003 on the left to 2015, you can see, just how greatly naloxone administration spread throughout the county. So it definitely wasn't confined just to the county seat. So maps can challenge what we think we know about a problem, right? So we might make certain assumptions about where a problem is and what we might need to mitigate the problem, but looking at the maps really gives us a deeper perspective of what's really going on. So when you think about all the previous studies that have been conducted on this topic, almost all of them have been conducted at the county level and primarily focused on the prescribing of opioids. Yet we know that opioid overdoses can have an immediate impact on families, and that impact might bring about swift involvement from Child Protective Services, particularly if children are present during the overdose event. Next slide, please. So, let's see, did I miss a slide? Next slide, please. Oh, there we go, perfect. So while maps can shed light on the problem, in reality, they might also be misleading. So we have to be careful with what kind of conclusions we draw from our maps. So for example, the map on the left shows child abuse rates in 2015. And the map on the right shows naloxone administration. And again, we're looking at the census block level, census block group level at Pickaway and Fairfield County. So looking at these maps, you might conclude that there's a correlation between the rates of maltreatment and rates of overdose. Yet when we run your statistics, the correlation is low and not actually statistically significant in this case. Next slide, please. However, if you look at past year, so 2014 rates of naloxone administration compared to 2015 rates of child abuse, the correlation increases and is almost statistically significant. So in this, to orient you to these maps, the left-hand side, you have child abuse rates for 2015, And on the right side, you have naloxone administration rates for 2014 for the same communities. So why is this important? First, it tells us that if we pay attention to these data earlier, we may have the opportunity for prevention. So, for example, what if we had a rapid response child abuse prevention team that we could deploy to areas with high overdose rates? They could offer evidence-based child abuse prevention programs. So would something like this have an impact on the child welfare system in the same way? A word of caution, for this map, we're just kind of trying to give you a little bit of a feel for some of the things we can look at. But in this case, we're just looking at a simple correlation, and we haven't controlled for the whole host of variables that I'm sure you can all help us think of that we know are related to maltreatment at the neighborhood level. But this is just to kind of give you a little bit of a taste of what we can look at. And the other thing that we want to note is that we do have an initiative here in Ohio that was started by our Ohio Attorney General and now the Governor's Office that has recognized this as a problem. So the initiative called Ohio Start was designed to have an earlier engagement with substance-affected child welfare families and to provide them with additional supports such as parent mentors and peer recovery supporters. So you might have some of those initiatives in your own communities as well. But as part of that initiative, we've been conducting some screenings for adverse childhood experiences, or ACEs, with all the parents who are involved in the Ohio Start program. Next slide, please. So I just want to pause here to talk about adverse childhood experiences, or ACEs, for a moment. So many of you are probably familiar with ACEs. Maybe that's part of the reason that you're on the webinar today, that you want to learn more about it. But I just want to make sure that we're all on the same page before we go too much further, just in case folks aren't familiar with ACEs or might need a refresher. So ACEs are potentially traumatic events that occur during childhood, and they can have a lifelong impact on the health of individuals as well as their future victimization and perpetration of violence. So examples of adverse childhood experiences, or ACEs, are abuse, and that can be physical, emotional, or sexual abuse. Also neglect, and that could be physical neglect or emotional neglect. And also things like household mental illness, incarceration within the household, domestic violence, substance abuse, or divorce. And so that's just kind of to give you an idea. So when we screen for ACEs, individuals receive a score between 0 and 10 that basically just outlines how many of these adverse childhood experiences they had between the ages of 0 and 17. So when it comes to trauma assessments like ACEs, the more adverse experiences you have, generally the worse your outcomes. So as the number of ACEs increases, the risk for health problems also increases. This includes things such as behaviors like chronic drinking, substance use, smoking, and also health conditions such as diabetes or asthma, obesity, depression, things like that. So we have a quick poll. We know that our ACEs scores can range from 0 to 10. So what percentage of Ohio child welfare involved parents, so parents who are involved in the child welfare system and have a substance misuse disorder, how many of those folks do you think report 4 or more ACEs? Less than 20%, 21 to 40, 41 to 60, 61 to 80, or greater than 81%.
And I see it looks like most people have voted. I'm just giving us a minute. We've got about 71% here who have voted. So let me share these results.
Okay, great. So it looks like the most common answer was 61 to 80%, followed by 41 to 60, and then greater than 81%, and then the smaller ones there. Okay, great. Thank you. Can we have the next slide, please? Okay, so thanks to everyone who completed the poll. The correct response was C, 41 to 60%. And you can see that on the right-hand side of the slide here. So we have our Ohio START population in the dark blue and the general population in the lighter or teal blue. So if you look all the way at the right-hand side there, you can see that 57% of our Ohio START child welfare involved parents reported 4 or more ACEs. You can compare that with the general population, which we had 75% had 2 or less ACEs. So definitely some significant differences there. So in recognizing that child abuse and neglect is a form of trauma and that many parents who engage in abusive and neglectful behavior, oh, sorry, I'm getting on the wrong page. The reason that the ACEs scores are significant, we know that ACEs scores of greater than 4 increase our risk for negative outcomes. So for example, with an ACEs score of greater than 4, your risk of diabetes increases by 390%, and your risk of depression increases by 460%. So these childhood experiences can definitely have lifelong consequences. So now that I've kind of oriented you a bit to the maps and how we use the maps to look at naloxone administration and also child welfare involvement, and also we've kind of touched on the ACEs a little bit. Now I'm going to hand you off to Bridget, and she's going to tell you more about our current study.
Great, thank you, Nicole. As we move on and start thinking about this next study, I want to thank our child welfare and behavioral health providers who provided us with this data. We've been able to look at a lot of interesting things that we hope will help them in the long run. So I always want to make sure that we acknowledge they've been great partners as we've been working on this study and helping us both acquire the data, but then helping us think through what some of the data might mean. So in this current study, we're really interested, as Nicole has said, at how opioid overdoses are related to rates of child maltreatment at the neighborhood level. As Nicole had said, our previous studies that have looked at this have primarily looked at this at the county level. But we know that sometimes what happens at the county level doesn't always translate at these smaller geographic units. The other thing that we're really interested about here in Ohio is, does the county type moderate this relationship? We have a lot of different types of counties. We have rural, Appalachian, suburban, urban. And the sense has been that it may affect these counties differently. And so we wanted to see if that actually is the case. Now, to talk a little bit more about the motivations for this current study. So in terms of spatial distribution of problems, one of the things that we notice is that depending on whatever unit of analysis you use, so census block groups are relatively small, and so that's why we can treat them as sort of your residential neighborhood. And counties are fairly big. And in some states, counties are really big, like in California and Ohio, they're a little bit smaller. And so when you're looking at problems by these different geographies, looking at these bigger areas makes it a little bit more difficult to figure out where within a particular county these problems are. So when we were able to drill down into neighborhoods, you could see the distribution across the neighborhood area much differently. And that might be able to help as we move forward in thinking about programming and providing prevention and services to these communities. And then there are also pragmatic concerns related to our diverse counties and their different experiences during the opioid crisis. For example, we know that often in our rural and Appalachian counties, they have much less access to services and often no access to detox within their own counties. So those present special challenges when you're trying to work with families, particularly families where substance misuse is a concern. And one of the requirements is to have these folks obtain treatment services. So we wanted to look out to see if we were seeing some of these different by our different types of counties. Now, for those of you who are not in Ohio, I thought I'd give a little bit of information about the state overall. It's the 7th most populous state. Race, ethnicity, it's primarily white, but we do have a sizable African-American population. 14% of individuals are living in poverty, and the median household income is about 54%. As Nicole already stated, we're consistently in the top 3 states with opioid overdoses. The other thing we've seen due to the opioid crisis is we've seen increases in neonatal abstinence from across the state. Now, when you look at this map, the smaller boxes are the census block groups, so you can see what those are. Then the different colors over them are telling you the county type. So our urban counties are in red, our suburban are in purple, our rural counties are blue, and our green counties are our Appalachian communities. Okay, so getting a little bit into the study design, and I promise to try not to get too nerdy when I talk about this. There are over 9,000 census blocks across the state of Ohio. Those were those smaller blocks that you showed you on the map. We're going to look at this outcome, both looking at referrals for child welfare investigations and substantiations in child welfare. In some of our earlier work, we see that you might have referrals in one location, but that doesn't necessarily, a lot of referrals in one location, but that doesn't necessarily mean that their substantiation rates are higher. So we wanted to look at both of those to see if we saw things slightly differently. As Nicole noted, we're using rate of naloxone administration as a proxy for opioid overdoses. Naloxone is the overdose reversal drug for opioids, so it stops the receptors from feeling the effects of the overdose. And so once that's blocked, then you come out of an overdose relatively quickly. Some more information on study design. As Nicole said earlier, when we were showing you some of those earlier maps looking at naloxone and child abuse, we were only looking at those 2 variables and conducting the correlations for those. In this particular analysis that I'm going to show you, we've controlled for a whole host of neighborhood variables, and I'm going to talk about what those are and what those might mean. So concentrated disadvantage, these are some of the usual suspects that you might include: unemployment rate, percent of female-headed households, but we also included something that is called the index of concentrated extremes. And so this measures at the low end the proportion of residents living in really low income areas, and at the high end it's sort of got concentrated wealth or concentrated affluence. So if you look at the range of the scores, you'll be able to see where there are neighborhoods that sort of have mixed income populations versus one of the extremes, either poverty or affluence. So it's loosely a measure of income segregation. For residential instability, we looked at proportion of movers in the past year and percent of vacant housing. Race, ethnicity, we looked at the heterogeneity, so we used something called a Blouse index. And basically, again, it's looking at whether or not it's a segregated neighborhood. So low numbers represent it's completely segregated. Higher numbers means there's a lot of diversity in that neighborhood, much more integration. Then often for studies using child maltreatment, when we talk about social disorganization, we look at something called child care burden. In this study, we measured as the ratio of men to women, the ratio of children to adults, and percent of 65 years. This is how we analyzed it. You don't necessarily need to know it, but I'm a nerd, so I sometimes feel like I always have to put it in. But I'll let us skip by it fairly quickly. So what did we find? Well, we found that at the neighborhood level, that naloxone rates over opioid overdoses, more of those, you had both more referrals and substantiations. Moreover, we actually saw that if you were in Appalachian County with high naloxone rates, you had even higher rates of referrals and substantiation for children. So going into this, one of the reasons the Ohio START program was started, and it first started in our Appalachian communities, because this was an observation that folks thought they had. So we were able to sort of empirically show that this has been the case, at least cross-sectionally, in 2015. So it provides basis that some of our communities were hit even harder than others when it comes to child maltreatment. Now, some of the other findings, I'm not going to go into them a lot, but percent of female-headed households, there was an increase using the index of concentrated extremes more as places became more affluent. You would see less maltreatment. more vacant housing, more maltreatment, the Blaus index showing ethnic heterogeneity again. You would see more diversity, there would be more maltreatment. One thing I want to say in this study, in this cross-section study, we didn't see any relationship between percent of unemployment and child maltreatment. And I'm going to come back to this at the end. Usually we do, so it's surprising that we didn't. But I think now in the area of COVID and what's happening with restrictions as well as opioid misuse that we see happening, that might come to be a bigger factor in the next coming months and years. One of the things that I want to say is just, we also know, so we also did the very similar analysis with the counties where we looked at the county rate of maltreatment longitudinally. And we did not see the same relationship that we're seeing here with naloxone overdoses. Really what we found is that past year were more important. So I'll show you a little bit about what that looks like. So when we did the longitudinal study, and I'm not going to show all the results for that, we looked at it from the 2003 to the 2015 time period. So we looked at what we call spatial lag. So we looked at, do neighborhoods next to us affect what's going on in our neighborhood? Is what happened in my neighborhood last year, is that predictive of child maltreatment rates this year? And then in neighborhoods last year that are adjacent to mine, do those overdoses predict maltreatment this year? And what we found is if you look at the local naloxone rate, so that's looking at the naloxone rate where I am, where I currently live, we found that to be negatively related to referrals and substantiations. So when you look at that at the block group level for just 1 year, that was positive. We also saw that spatial labs where you were next to, that was negatively as well. But when you start to look at the time lags, the previous year and the space-time lags, that's where you start to see this positive association. So the reason why I think we need to continue to conduct these studies and conduct them at smaller geographic levels is because we do see different relationships at the county level than we do at the smaller units. And we're not quite sure what this is, but I've seen these time and space-time lags come up in studies of drug availability and child maltreatment often now. So I think that there is, when we get to the conclusions, I think that there is some sort of mechanism that's occurring that in those areas right where the overdoses are happening, we're obviously going in and doing investigations if they involve parents with kids. It might be that over time, and you start to see these clusters of where these overdoses are happening, is that maybe you start to get concerned and are more likely maybe to have calls for referrals of investigations or substantiation. So we're not sure what that looks like, but we've been talking to our partners about what they think might be happening that allows us to see this different relationship at the community versus at the county versus the neighborhood level. So again, just looking at that, these are the two. It was all the stuff past year that was related to child referral and substantiation rates in the current year. Conclusions and implications of sort of this work. At the neighborhood level, we are seeing that opioid overdoses are related to involvement in the child welfare system. But in some neighborhoods, in some counties, it matters more. So specifically in our Appalachian counties, again, this is really important to note because our Appalachian counties often have a different culture than the rest of the state. They have less access to services. They also have less access to technology or technology that's not very reliable. So it can make providing services in those areas more difficult. The use of epidemiological data in this might provide insight to how we can respond quickly to overdose clusters. So based on these cross-sectional findings, if you know that a particular area, a neighborhood, is seeing a spike in opioid overdoses, it might make sense to figure out, could you have, like they often have now with places where naloxone overdose does, the ER has a quick response team where a social worker, maybe an EMS person, some other folks will go in and try to get the person who has been revived using Narcan or naloxone into treatment quickly. So is there something similar that we could do in the child welfare system when we start to see those spikes of overdoses occur? So something to think about in terms of how do we prevent and work with these families. So some other conclusions and implications, as I've stated, neighborhood and county results differ. And there are some things in geography called the modifiable areal unit problem and change of support. Basically what this means is that when you aggregate different data to different levels of aggregation, then it can mask sometimes some things that you might see if you had the smaller level of geography. Now, in studies of child maltreatment, it's often been very difficult to get data that goes really down to the small level. You might not be able to get exact addresses. You might get data that's already aggregated to the census tract. Here, we've been incredibly lucky that the state of Ohio has allowed us to get point located data, so basically addresses, so that we can map those and then have the ability to look at these relationships at a very small scale. And so we're able to see different relationships that you might not see at the county level. Also, because there's this difference between neighborhood and county results, there might be some implications related to timing of when we might see problems. And so looking at things that happened in the past year, the past month, might be really important related to how we think of maltreatment. This, I think, this last implication I talked about, I think becomes more important in the era of COVID. As a lot of you know who are out there, we're already starting to see fewer referrals for investigations in a lot of places, fewer substantiations, but there's this great concern that this isn't going to hold. That right now these families are having less contact with mandated reporters, with teachers, those kinds of people. And so when the restrictions are lifted a bit and we're allowed to sort of roam out more, we might see those reports go higher. So one of the things that in thinking about how you look at the pandemic as it relates to child maltreatment and substance use actually, is you might have to look at past month, past 2 months, things like that to look at what the relationship is now. So for example, we know that unemployment in Ohio, as it is in almost every other state, is skyrocketing. And so if we look at unemployment rates as they're happening now, those might affect the referrals for investigations we see in the next coming months when people are allowed to leave their homes more often again. We're also seeing on the ground, we're doing a lot of projects with a lot of the counties here in Ohio. Obviously, there's a change in family visits. There's change in contact with peer supporters. So a lot of this is now trying to do video where possible, do telephone calls. Again, in our Appalachian communities, access to internet and technology can be a big problem. So we worry that the intersection of substance use and changes in the child maltreatment system in order to keep people physically safe might further affect our families adversely. One of the things we've already talked to several of our counties is they're already starting to notice relapse rates are going up among some folks. So not being able to see their kids physically on a regular basis has been a problem. Drug courts have also had to change their procedures. And so not having that weekly accountability, the caseworkers I'm speaking with have said that seems to be an issue in this as well. So we didn't think that we could sort of do this presentation and not acknowledge that COVID-19 is probably going to affect what happens in our neighborhoods, both on the substance use arena and child maltreatment arena, at least over the next few months, but probably over the next few years. So that's something to be thinking about as we think about what we can do to prevent and support families where substance use is a major concern. So we have a whole bunch of next steps in terms of the research. We're going to start looking at the neighborhoods over space and time. So we were able to do that at the county level. We're going to do a similar study at the neighborhood level where we can look at past year naloxone rates, whether the naloxone rates happened in the local neighborhood or adjacent neighborhoods. We also want to identify these high and low risk areas. So there are some areas that even though they score high on social disorganization, they have high poverty, there's a lot of vacant housing. When we do these models, they're doing much better than our models predict they were. And the vice the opposite is also true. So we have areas that we would expect would be doing really well, but they're not doing so well. So we want to look at those neighborhoods that are on the extremes and really start to figure out, well, what's going on in those neighborhoods that are doing much better than we would expect? You know, is there something at the neighborhood and local level? Maybe it's access to services. Maybe it's that it's a tight-knit community and people look out for each other more. So we're going to be doing interviews with folks in those areas to get service providers, some families, to really get a sense of what people think is going on the ground. We'll also do the same looking at those that are doing worse than expected. And so what's going on in those neighborhoods that, given the conditions they have, we would expect them to be doing really well, but they're not, that they have higher rates of child maltreatment. And so this will give us some idea in thinking about what could we do in the future to prevent maltreatment, particularly as it relates to opioid misuse, overdoses, and child maltreatment, those interventions that maybe we could implement and think about doing. So that is all we have right now. Thank you again for listening to our presentation. And I think we're at the point where we take questions. Is that correct, Sarah?
That's right. Thank you so much. That was a great presentation and a lot for folks to think about. And we've got a few questions coming in, but I want to invite everyone to put your questions into the Q&A box now. Nicole and Bridget, I think, the first kind of batch of questions, some came in from respondents, from participants, and one is my own, is just kind of around data and definitions. And so the first one that I wonder if you could speak to is just for those of us that are not as familiar with Ohio. You talked about having urban, suburban, rural, and Appalachian counties. Can you talk about the difference between rural and Appalachian, and why you have a special category for those counties and more about what they look like?
Sure. Our Appalachian communities are primarily they're exclusively on the eastern part of our state, and they are part of the Appalachian Mountain Range. And so historically, those groups of counties, and they include counties in West Virginia, some in Kentucky, and some in Pennsylvania, they have historically had more structural disadvantage than other counties. And so they have, again, part of it has to do with the technology. There used to be a lot of jobs around coal mining, and when those went away, it has left a lot of those areas, unfortunately, pretty disadvantaged. Our rural counties still are the same in that they have lower populations, but they have often had more access to jobs through industries, manufacturing, factories, those sorts of things. And so traditionally have done a little bit well on some of these social and economic indicators.
Great, that's helpful, thank you. The next question came in from Amanda. She wants to know more about your those reports of naloxone administration. Where do you get that data, and does it include naloxone administered at home by family and friends, or is it only administered by professionals?
That is a great question. The naloxone administration data we have that's been administered by EMS providers. So that's when there's been a call that there's been an overdose. Our emergency medical service technicians go out and then administer that. So it is that way. It does not include, in this particular study, it does not include those instances where they were administered by home or other papers, or for example, if they got to the ER first and were administered at the ER. We don't have that in this particular analysis as well.
Okay, thanks. And then Paige asked a question going back to the slide about ACEs scores in the child welfare population, about whether you're talking about the score for the child or the adult. And I think you said you were referring to the adult in that scenario, but can you clarify that for Paige?
Yep, those are from the adults. So those were adults who were enrolled in the Ohio START program. And so looking back at their childhood, how many of the adverse childhood experiences did they experience while they were growing up?
Okay, great. And then someone else wanted to know more about neonatal abstinence syndrome. Can you talk a little more about that? what it is and how it's counted?
Sure. So neonatal abstinence syndrome is the diagnosis that children who are born addicted to opioids receive. And so as women who are using opioids give birth, there's all this is a complication that happens, and the babies then have to go through a process to withdrawal from the opioid misuse. And so that is called neonatal abstinence disorder. It often means that these babies have to stay in the NICU for a while, and there is a process by which withdrawal has to occur for these babies before they can either go home or oftentimes they'll go to foster care. So it's diagnosed at birth and handled at that level.
Okay, thanks. And a couple of more questions related to your analysis too. Sarah wants to know, were the social disorganization indicators treated as moderators? And can you discuss those results a little bit more?
Yeah, so for social disorganization in this first analysis, we treated all of those as just predictors, not as moderators. The only moderator that we did was county type by naloxone rates. So it would be the case potentially that naloxone rates are moderated by, say, for example, income segregation or percent of vacant housing, but we did not yet look at those in this particular study.
Okay, and how about race? Were your data disaggregated by race?
I assume that the question is about the race of the children. And in that case, we did not do that. We actually do have that information, but have not looked at that, had a chance to look at that yet. We also have planned to look at this by age to see if age matters of the child. If children are older, maybe there's less likely to be a referral or a substantiation. And so those are planned analyses that we have not yet conducted yet. But stay tuned.
Great. And we did get a question about whether your results are published anywhere yet.
They are written up. We have to send them over to Ohio Department of Ohio and Job and Family Services to have them checked to make sure how we talked about the child welfare data is correct. And so when we get that back, we'll be submitting them for publication. Almost, not quite.
Great. Well, and maybe you can come back and speak as well when you have your qualitative work done, because I think that sounds really interesting and will help kind of add some new perspectives into your data. We also have some questions around prevention that I want to put to you all. You spoke a bit about how this type of spatial data can help target prevention and kind of do some rapid response when children may be at risk in certain communities. And a question that I have is just, are there prevention strategies that are especially relevant for these communities? Do you have thoughts on kind of what that prevention approach could look like? Is anywhere doing that right now and using this kind of data? Or how do you envision that playing out, and what supports would be useful in these circumstances?
That is a great question. We don't know of any places that are doing sort of this rapid response, at least for child maltreatment. This rapid response, these teams do go out now around overdoses in general, and are doing that in more and more of our local cities and jurisdictions across the state, because they're finding that they need to have this warm handoff to treatment. And just sometimes when you revive someone from naloxone, they don't see the need to go to the ER, or they're not quite ready to go to treatment right at that moment. And so if somebody comes out a day or two later, they might be more amenable or open to the suggestion. So the idea of doing this with child maltreatment would be, if there are children involved, figuring out if there's a way that those children can be safe. I know child welfare systems here in Ohio, because we have seen such an increase in out-of-home placements and in child maltreatment rates, that, you know, if they can find a place, can develop a safety plan for the child, that doesn't necessarily mean formal involvement, maybe only voluntary involvement with the child welfare system, that's preferable. So these rapid response teams, if you will, could go out and sort of assess that, to try to prevent removal into the foster care system and find ways to keep the children safe. One of the other things that we do worry about, and this goes beyond just opioids and child maltreatment, but neighborhood factors in general, really will have to do around income status, changing income, unemployment, because we know that those are often big predictors of child maltreatment. And so thinking through what that's going to mean in these families and what supports they will need, if their income supports, other primary prevention services that could happen, that might be something we could do. I will say with Ohio START, the model that we're using for START has been tested in Kentucky and some other places, and the use of these parent mentors to work with families, even if it's on a voluntary case, that they seem to be providing families with support in a lot of different areas around sobriety, around what it's like to be involved in the child welfare system. So at the individual level, this is something that's promising, and that we're evaluating its use here in Ohio, with the idea that we think it might be preventing maltreatment in the future, preventing reoccurrence, but also it might be allow some of our families to be able to have their children reunified more quickly, or to decrease child welfare involvement at a quicker rate. Nicole, did you have anything you wanted to add related to prevention?
No, I think you did a good job. I don't have anything else at the moment.
That's great. Thank you. Silver had a question specifically about social workers providing services right now by video chat and phone call. You know, anything around prevention and services specifically in this context with COVID-19 to support families?
So there are a couple of things that we're noticing here in Ohio that it sounds like might be trends in other states, that child welfare agencies, if they haven't been thinking about it, they probably will. One of the biggest concerns we have is that parents often don't have enough minutes on their phone to be able to do chats and have phone calls with their kids. Same with having services with their substance use provider or their peer recovery support. So it's often been difficult for them to maintain those relationships if they don't have access to a phone with enough minutes, or with unlimited calling or unlimited data plans, in addition to some of the technology challenges that we have in our rural Appalachian areas, where you often don't get service in a lot of places. So we've noticed that to be sort of a barrier that folks are concerned about. Ohio is trying to be very proactive in this. I know that there are discussions at the state level with the cell phone providers of some of the main plans that are used, to see if their rules around minutes and things like that can be changed for a lot of our vulnerable families, in order to allow them to have the extra capacity to stay in touch with family and their treatment providers. So those are some of the things we've heard. I'm sure there are other similar or different challenges in other communities that we'd love to hear about that as well.
Okay, thanks. And we have another question from Emily. She wonders if you have any hypotheses as to why some of those communities that are doing well, why some communities are doing well even though you thought they wouldn't do well. And do you have any hypotheses about the opposite too? And what could be driving that?
Yeah, so if you look at the stuff that we've been measuring, that it uses census data, it uses administrative data, what it doesn't really talk about are a lot of the social relationships that might be happening. So there might be levels of social support that exist in areas that maybe are economically disadvantaged, that really provide buffering and support from those negative effects of living in high poverty or extreme stress, those sorts of things. And the opposite might be true, that even if there is higher income, you might be fairly isolated from other folks who don't provide that support around parenting that might again buffer you from abusive or neglectful parenting. So I think that's probably one of our big hypotheses. And then, Nicole, I think we also have some hypotheses around service provision in those areas as well.
Yeah, exactly. So, what kind of resources are available in the community? Do people know about those resources and access them? Because sometimes you can have communities where there are, theoretically resources available, but people, for whatever reason, don't feel comfortable accessing those resources, or the resources aren't available at times that are convenient for the members of the population and things like that. So that's really what we're going to get into in the second part of our study. The qualitative piece that hasn't started yet is to really try to tease out what those factors are.
That's great. Well, we will all stay tuned. I think, your work raises a lot of really interesting questions. We'd love, as I said, for you to come back and share more when you have more findings to share. But I want to thank you both so much for taking the time to talk about your research today. And thanks to all the attendees who joined us. I'll send out information, the recording and the slides. And also please sign up for our future webinars if they're of interest to you. We'd love to have you back again to join us for another webinar. So again, Bridget and Nicole, thank you so much. And I hope everyone has a great rest of your day.
Thank you, Sarah.
Thank you.